to talk about ST elevated myocardial infarction. With interest, I will talk about cases. This is a 56 years old patient, male patient, very recently came to me with central tightening, severe chest pain for 1 hour. Past medical history, he has diabetic and hyperlipidemia. And blood pressure was about 100 by 70, but lungs are clear. And SpO2 saturation was normal on admission. So, so then how do you assess, how to approach this patient? Actually, the guideline, without guideline also, you should approach this patient like ABC approach. You look at the patient vitals, and then you, as soon as possible, these patients measure the blood pressure, and then they take a ECG. If the ST elevation is there, then you have to think of what are you going to do, how you approach ST elevation patient. Whether you are seeing this patient on Anuradhapura ETU, whether you are seeing this patient in peripheral hospital ETU, whether you are seeing this patient in maybe your private practice. And how to approach this patient is different. So, but of course, so the objective is as early as possible to open the artery. So then that is the objective of this patient of approaching. So then this is the ECG of that patient, which shows right bundle branch block with ST elevation in an extensive anterior myocardial infarction with ST elevated. And by looking at this ECG, if you look at this ECG, there's a high risk features because it's having bundle branch block plus ST elevation, and extensive all the leads have ST elevation. So then, so what are the criteria to diagnose STEMI? So now 2023 guideline says the for male below 40 years, 2.5 millimeters of V1 to V3 ST elevation, or above 40 years, at least 2 millimeters of ST elevation V1 to V3. For female V1 to V3, 1.5. But of course, all the other leads, 1 millimeter ST elevation is regarded as ST elevation MR. So let me be clear. So then if, for the male, at least V1 to V3 only change. For male, it is above 2 millimeters, above 40 years, and below 40 years, 2.5. And then all the other leads, 1 millimeter. For female, V1 to V3, 1.5. And then that is one criteria for ST elevation. Then other patients who working with ST elevation pathway are ST segment depression in V1 to V3 with positive R wave and V7, V9 ST elevation. That's a posterior MI where you can thrombolize even. So then other is the AVR ST elevation with universal ST depressions with given clinical history of chest pain and setting we regard as STEMI. Then left bundle branch block or right bundle branch block on admission with a relevant clinical history, you have to triage as STEMI. And then pacing rhythm, if they have very significant chest pain with those are the patients you should go through the STEMI pathway. And so then if you look at, because our president wants me to show this regarding, this is inside the coronary artery, what will happen with the aging, you develop, the patients are, everybody has, developing their, when the cholesterol is high, plaque formation in these, in the coronaries. These plaques are stable plaques, they are asymptomatic. But of course, with the time, with the aging, that can go up. With the cholesterol is high, diabetic is there. But of course, most of the time, it is asymptomatic. So then when it is blocked more than 70%, those patients get chest pain when they exert. That is called stable angina. But of course, there's no emergency there. There is a chronic coronary disease. But of course, then those patients can be identified by XICCG or other tests like CT angiogram. But of course, when some patients, these plaque rupture occurs, where then the plaque rupture occurs, this is the plaque rupture with the clot formation. You will see this is a non-STEMI where the flow is there, but there's a clot inside. But of course, when it is progress more, it progress up to the level totally blocked. And then it is a medical emergency. So then that is causing a ST elevated myocardial infarction, where the non-STEMI is a medical urgency, STEMI is a medical emergency. So then when it progress beyond certain limit, you get a STEMI like this, fully blocked. So then there's a clot inside the coronary artery, which is which has actually platelet clot, and then the fibrin and red blood cell deposited clot. So we have to how do you approach? So in this patient admitted to the ETU, so we approach like look at the airway circulation, breathing, and then give oxygen only saturation down. If now the class if the routine oxygen is discouraged, it is not to give actually. If the SpO2 is more than 90, you don't have to give oxygen. So then pain relief, of course, you have to give morphine, and then decide on mode of reperfusion, whether patients can be directly sent to cath lab and stenting, that is called primary PCI, or whether you are going to offer him a thrombolysis, fibrinolysis, right? So then, so decide on mode of thrombolysis before giving the drugs. So then give the antiplatelet drugs, right? So then, so if you look at the timing of the deciding on mode of revascularization is important. How to decide that? Depending on the available facilities. So when you ask this ETU provided this STEMI come to this ETU, you should contact on-call cardiologist. But only things, you know, this in our country we are running another list in the cath lab. We are very busy. Sometimes we might be operating very bad patient on the table, because we are doing the routine list or everywhere, that we don't have a dedicated cath lab for primary to do. So then you might be, the cardiologist must be busy with doing a very major case, might not finish about 2 hours. So then you have to talk to him and ask whether you can take the primary, because we are running a routine list plus emergency. But most of the time we try to accommodate, but of course sometimes very busy. So then then maybe thrombolyze. So then that depends on the cath lab availability. Of course, these guidelines says, but if you can give if the patient come to primary center like this, if you can do it within 60 minutes is the time to do a primary. But of course, if the patient comes somewhere near hospital, within 90 minutes we have to do. But if it is delay more than 2 hours, thrombolysis is better than. So then thrombolysis and transfer is better than directly sending for primary, because that is very important to talk to your on-call cardiologist and find out whether how he can accommodate the patient, because we are running both lists. And then so then once you decide whether you are going to thrombolyze or then whether you are going to do the primary PCI, you will decide on antiplatelet therapy. The primary PCI patient, you can give aspirin 300 and clopidogrel 600 or prasugrel or ticagrelor. But of course, these are very expensive. If you look at so afterward, if you give ticagrelor for 1 month, it will cost about 15 to 20,000 rupees for that drug only. So most of the patient not affordable. So giving single dose doesn't give the benefits. Prasugrel giving 1 month costs about 7,500 rupees. So then we have to, so most of the people, because only one drug costs that much of drug. So then so then aspirin clopidogrel, I ask them to give most of the time aspirin clopidogrel in government sector, because they can't afford. So then, but of course other drugs are beneficial. But this is not guideline indication. Guideline does not ask to do the heparin preload. But I ask all the patients to heparin 5,000 preload at the ETU when you take to the PCI. Why? There's time delays. We can't do that on that time. There's time delays. We might be doing some cases and then we can't do within 60 minutes. So sometimes we take the primary, we are doing a case. So then we give heparin. So then there's no evidence at the moment. But I think I think most of the cardiologists are doing that. We give the heparin 5,000 at T2 and get into the cath lab. And then when we approach the patient. So then when we are doing the angiogram, we give little less heparin. If you are going for the fibrinolysis pathway, the antithrombotic treatments are aspirin 300 and clopidogrel 300 only. No prasugrel, no ticagrelor, bleeding risk is high. If the patient is more than 75, now they don't advise to give a loading dose, only clopidogrel 75. That is a guideline, 2010, right? And then this one previously shown, because other important thing is if you give aspirin on time to a patient with the ST elevation time, because ST elevated MI, if you look at this pathway, initially platelet aggregation occurs, then thromboxane pathway can be blocked with aspirin or P2Y. So then if you look at the platelet act on the P2Y receptors, So then if you can give the aspirin clopidogrel, so then what will happen? Most you can have open artery when you send to a center about 20%. So giving aspirin early because there's no red blood occurred. When I have seen a lot of GPs are seeing patient and then they don't write anything because of medical legal reason. They don't give any medicine. They send just please give aspirin 300 and clopidogrel 300 to that patient. No harm. So then you diagnose that, give, then when by the time patient comes, might have ST elevation has gone down because it can open the artery within time. Early if you give, because the platelet aggregation occurs first, then the red blood cells come. So if you look at the pathogenesis. Then if you look at the other drugs, we are actin factor 10A, enoxaparin and apixaban, thromboxaban and rivaroxaban act on factor 10A, and unfractionated heparin act on factor 10A and thrombin. So then we use these drugs also for when we are treating STEMI or patient might be on. We have to know that. So then if you look at the doses of these drugs, of course, you have to be additionally careful using prasugrel. This is an irreversible platelet inhibitor, which is very powerful. So then above 75 years when you are using, you have to be very careful. Unless really necessary, you should not use. You might reduce the dose or see. So then other drugs you can use with irrespective of age. If you look at even Trecogilo, they don't comment about the age. So then Cangrilo is not available in Sri Lanka. So then I'm not going to. So then IV metoprolol. So then IV metoprolol, of course, there's a benefit of using class 2A indication to use IV metoprolol, provided the diagnosis of STEMI is confirmed, and then the metoprolol is the only studied drug, and then the blood pressure is more than 120 without no pulmonary edema. If you give these patients metoprolol, that will reduce I think microvascular obstruction. This will understand by cardiologists. The microvascular obstruction, and then arrhythmia risk and ischemia reduction is there. But of course, you can't give non-STEMI patients. There's no evidence for non-STEMI patient giving IV metoprolol. So then you can give IV metoprolol for those patients going to cath lab. Only not for thrombolyzed patient. Only for primary PCI patient there are evidence. So then what we do in the cath lab, I'll show this. Actually, this is a femoral angiogram. We should do in radially. That is proven to be benefited. That is has a radial approach is having more benefits, like bleeding risk is less. But I couldn't find anything. So then we go to the heart like that, and we find out the block, and we insert a wire through, because a lot of people have not seen. So then we balloon it like this, balloon the lesion, and then take the metal mesh that is called stent, which is medicated. There are we are using 100% drug-eluting stent, and leave the stent and come out. That is a stent. So then it is a patent artery. So then this is the first patient I was talking about. If you look at this carefully, I think because you are not used to, you might not see. If you look at these top two panels, the LAD you can't see. Once you open, you can see very nice. All the branches are flowing. So then this is life saving, and not only that, this is myocardial saving. They don't go into heart failure when you do that. But of course, you have to do in time. Okay. So then if the primary PCI is not available, what you do? Then you have to go for the fibrinolysis pathway. So then fibrinolysis pathway is actually the lytic therapy. So then, so we use, if ideal, we can use tenecteplase. Sri Lanka now it is available, but of course these days sort of supply, but of course it's very expensive drug, but very effective. If you are using tenecteplase, you use as soon as possible. Giving is very important, because clot is progression, then the effectiveness goes down with the time goes down. So you within 10 minutes, once you diagnose, you give very quickly. And then only thing is, if they are above 75, you can give the half dose. And then thrombolysis fibrinolysis is class 1 indicator when the patient has chest pain occurs and within 12 hours. That's it, right? So then when you are giving the prebutylates, you give IV enoxaparin plus enoxaparin for index of 8 days, they say. But of course, at least 5 days if you are not sending for PCI, because it occurs reinfarction when the clot is dissolved. When the clot is dissolved, so then but there's a wound inside the artery. That to heal, you have to give enoxaparin, otherwise reinfarction occurs. Right? So then if you are sending for primary PCI or later PCI, we can start enoxaparin. So then what are the doses? So the streptokinase you are giving about 1.5 million units. So then I'll talk on that. We don't use alteplase, even though we have, and retiplase 2 injections. Of course, tenecteplase is weight dependent. We give about the half the weight. You know, the 60 milligram patient give a 30, 40 now, like 70 milligram 35, 80 milligram 40. So then the half the weight is the dose. Up to 90, beyond 90, you give whatever the weight is above 50 milligram. And then if the age is high, you can give the half dose. And absolute contraindication you should know, but of course relative contraindication we bypass. We can assess the patient and risk versus benefit you can use. But absolute contraindications are previous intracranial hemorrhages or stroke of unknown origin at any time. Ischemic stroke preceding 6 months. Central nervous system damage or neoplasm, AVM, and recent major traumas within 3 weeks, and GI bleeding within past 1 month, known bleeding disorders, aortic dissection, and then non-compressible punctures like liver biopsy within past 24 hours, they say. So then when you compare these 3 agents, streptokinase to tenecteplase, if you look at this, what is the efficacy of giving this? If you look at if you give the streptokinase, about 30 to 50% of patients artery will be open. But if you give tenecteplase, about 60 to 75% of the time artery will be open. So then what will happen? Even you give the fibrinolytic, the game is not over. So about streptokinase, half of the patient chest pain settle. How it settle? Completion of infarction. They complete infarction and then so then they are going to do heart failure, arrhythmias, and they can't do the job. So then you need to find out what are the patients, these patients. If you tenecteplase, more patients are thrombolized. Then the other thing is, if you look at the younger the patient, when you thrombolize, because their plaque, underlying plaque is very small, their clot is bigger, their thrombolysis success is high. We see a lot of young patients thrombolize coming, we don't have to stent. The older the patient, so then their plaque is bigger, clot is small, so then there will be residual plaque. So then that is also, so younger patient, if you early success, that is the best thing. If you thrombolize, when they come, we don't have to put stent, so then don't have any stent in the, okay. And the cost is varying. Of course, Sri Lankan cost, streptokinase is about 3,000 to 4,000 rupees, I think. I think now tenecteplase is about 2 lakhs. So that's the cost, right? Yeah, you have to give 2 lakhs. So then the cost is very high, but it's a good drug. Cost is very high. So then how to assess whether it is success or not? Thrombolysis. After thrombolysis, if the patient's chest pain improves, they are clinically improving, and improve blood pressure, improve heart rate, improve the heart failure signs. Those are very important. And then ECG criteria, about 90 minutes you do the ECG, you look at the highest ST elevation lead. Highest ST elevation lead, 50% reduction also regarded as successful thrombosis. So then the patient has a flow in the artery. Those criteria are fulfilled, the patient is getting the blood into myocardial. But accelerated idioventricular rhythm is another feature, which is like a slow VT. If you look at the background, the ventricular origin, but of course you can see middle capture beats with a normal rhythm. That is called accelerated idioventricular rhythm. This is about below 100 usually. So then it is also sign of
suggest
if unsuccessful, you send for PCI very quickly. If successful, also the guideline says to do a PCI within 24 hours. If unsuccessful, immediate PCI. If successful, tomorrow morning you can do PCI. That's a guideline. But of course, whether, right? So if you look at this is a guideline, so then all the patients with STEMI should go to the cath lab ideally. So then if you go through the if we can do the primary PCI, maybe all the patients is cheaper than thrombolysis, because thrombolysis cost is very high. If you thrombolize and do the PCI, cost is very high. But of course, we don't have the facilities for primary PCI all the patients. So then all the patients ideally class 1 indication to go to cath lab. So after pregnancy, what do you do? So then patient should be monitored in the ideally CCU or cardiac monitor to look at the arrhythmia. And then start the oral drug like beta blockers. Why we start beta blockers? Beta blockers the earliest drug to start should be beta blocker. It will prevent arrhythmias and short-term death. VT reduction is there. Long-term benefits are there on beta blocker. So then if you can start one drug, that is the beta blocker first. The blood pressure permits to start one drug, so you start the beta blocker first. So then the statin should be anyway started. So then high dose statin, and then ACE inhibitor, if the blood pressure permit, you can start. So then if you choose the beta blocker to ACE inhibitor, ACE inhibitor can be delayed little, but of course beta blocker should be earliest started. And then PPI, proton pump inhibitor, also class 1 indication if the patient's bleeding risk is high. That has a survival benefit if the patient risk is high, bleeding risk is high. I count that. And then if the EF is low, you can start spironolactone. So those are the drugs you should be starting on the patients. So then my patient has diabetic. Ideally speaking, these drugs are having survival benefit. Metformin and SGLT2 inhibitors and GP1 agonists we don't use, but of course other two are widely using, which can be used for diabetic patient with MI. So then insulin, glycoside are like cardiac neutral. There's some are cardio. There are event rates goes up by older generations like glibenclamide and all, right? So then if you want to start diabetic drug, these are on this patient. So the general care of these patients, so you should be monitored for arrhythmias, and then you look what are you looking for CCU or ward? Look at the renal function like input-output chart. Look at the patient conscious level like brain perfusion, and then patients, if the bowel is not opening, give laxative. Why laxative? So because constipation can cause arrhythmias and cardiac rupture. MI patient, that is being proven. So then patient might be anxiolytic. You might need to give little anxiolytic on these patients. So that is important, right? So then diet guideline, I know a lot of people keep fasting in my patient. You don't have to. So then you give a very easy digestible food, low protein, low fat, small quantities, and then low acid because of the stress ulcers. But when the patient is hemodynamically stable and the pain-free, you can start the drug. You don't have to keep the patient fasting, right? And then this is a general guideline. So we keep bed rest about 24 hours and then allow to walk if the patient is hemodynamically stable within 2 to 3 minutes of metabolic equivalence of workload for day 2. Of course, we discharge in day 2 now. All the patient, National Hospital, following day morning we discharge because we don't have bed. And today we do the primary, following day 99% we discharge. No? We don't keep. So then if the EF is above 40, we discharge. So then, but of course, so then you can keep about 48 to 72 hours. But of course, thrombolized patient, you should give enoxaparin. So index of at 8 days, at least 5 days, you have to give enoxaparin. So then the thrombolized pathway is also very expensive. Like enoxaparin, 5 days stay, all this. So then long-term antithrombotic, I think our president talked about this. I think I will not touch much, but if you look at here, so we any patient with thrombolized patient or PCI patient, long-term prasogil, ticagrelor are better than clopidogrel for dual antiplatelet. After thrombolized, you can switch. But and if you have done the PCI, prasogil is over ticagrelor is preferable. So that is the guideline. So then you give aspirin and P2Y inhibitor for 1 year minimum of, and then after aspirin. But of course, I think our setting, clopidogrel is a good drug, whatever it is. But clopidogrel has problem. But of course, we generally use clopidogrel about 99% of our patients. And this is also, if the bleeding risk is high, you can give 1 month dual antiplatelet, and then if you are giving long-term P2Y inhibitor only, that is they recommended to give either ticagrelor or prasugrel over clopidogrel, right? So then, if the bleeding risk is not high, you give at least 1 year. Okay. So then, what are the patients of high bleeding risk when you are going to intervention? So what are the things? Patients who are on older patient, especially women with older patient, has a high bleeding risk. So then, if you are doing, as I said, the radial is good, and then PPI is indicated with the patient with dual antiplatelet with high bleeding risk patients. If the patient use steroid or NSAIDs, previous hemorrhage, on anticoagulant therapy, age more than 65, dyspepsia, and then chronic alcohol use, these indications are there. You can use, there are benefits, right? And then if the patient, for us actually, if the patient is on anticoagulation therapy, PCI perform without interruption of vitamin K or NOMAC, and then, so then if the INR is more than 2.5, we don't use, you should not use unfractionated heparin during the procedure. And if the patient is on rivaroxaban, we can use, irrespective of the last dose, you can use the half enoxaparin of 0.5 milligram per kg IVO, unfractionated heparin 60 units. That is the recommendation. So then, anyway, like, you know, we don't have tirofiban and 2B3A inhibitors, we don't have in Sri Lanka. Only we have afliximab, which is we use operatively in the cath lab. It is available, we use when there's a cost. Others we don't have. Okay, sorry. So then the second patient, this is a 65 years old female, chest pain with dyspnea, past medical history. This has been talked. So then, but anyway, hypertension, AF, and diabetic. On admission, her blood pressure saturation is slightly low, tachycardic, and the blood pressure is okay. This is the ECG. How to approach? You can see ST elevation with Q waves, and the T inversion occurs on this patient. And then if you look at the history, the chest pain is and dyspnea is vague. So then how to approach? So this patient was, ideally speaking, this patient was on now warfarin and coming with, we don't know the INR. So then, and then onset of chest pain is not clear, and patient is on warfarin, and ideally this patient should go to cath lab. That's the preferred anyway. But if the patient is not, if the cath lab facilities are not available, how do you manage? You look at the chest pain, onset of chest pain less than 12 hours, whether the INR is therapeutic. So and then the decision is made on hemodynamic is stable, pulmonary edema is there, you can't send to cath lab. So then, but the INR therapeutic, you can thrombolize. But there are no evidence, but of course, only evidence are for thrombolysis with normal INR is valve thrombolysis has been done safely. Then when the valve thrombosis comes, so then we are thrombolizing on INR therapy. I got recently INR about 8 with, because all the patients admitted to valve thrombosis are high INR because they are stopped warfarin. When they get dyspnea, they take a lot of warfarin tablets and admitted with high INR, almost all. So then I got recently about last week. Okay. And then evaluation of chest pain, I'll go. Evaluation of chest pain, this is important, no? Evaluation of the ECG changes, hyperacute T, and then ST elevation occurs within minutes, Q waves occurs within hours, and then Q waves with T inversion occurs beyond 12 to 18 hours, Q waves with, yes, and then Q waves after T inversion comes to normal within 4 to 6 hours after fibrosis occurs. So this patient has anyway Q waves, ST elevation with T inversion. This also shows little older MI. And then patient underwent primary PCI. With this, patient was given aspirin, clopidogrel, and rivaroxaban for 1 week, and then aspirin and rivaroxaban. Right. So then, so this is the guideline. So then, because of the time, I'll go to the next case. This is the patient with 42-year-old male, central chest pain, past medical history, nil, admitted with BP of very low, pulse rate of 40, saturation normal. This is the ECG on admission. So you see ST elevation with low blood pressure and complete heart block. How to approach this patient? Actually, so then if you can still do the primary PCI with the pacing is the ideal, but of course, otherwise you give atropine. Atropine will improve the heart rate and then sometimes the blood pressure as well. And you can give atropine and fluid. So this patient's blood pressure is low is different to, this patient's blood pressure, low. Right. If you look at this patient, what is this patient has an inferior MI with a posterior extension. If you look at fluid resistance, if you look at that is the V4R, V4. So that is, so if you look at this patient, that the not V4R, that is the lateral lead more V7, V8. V4 is V7. SC elevation, all those. If you look at this patient is an inferior MI with a posterior extension. When you resuscitation on fluid, this patient should be careful more on to other inferior MIs. Why? LV dysfunction is there on this patient. Right? Okay. So then, so this patient, because LV dysfunction is so there. But of course, if you look at this patient, is different to this patient. First patient is different. That patient blood pressure reduction is due to low heart rate. Of course, this patient posterior MI as well. You give the fluid, but of course, lung base should be seen. Sorry. So then, this is an, yeah. So, sorry, I can not. Sorry, this is a sorry. That's a V4R. So this patient is sorry, I missed up. Actually, I can't see there. Side is covered. So then that is a V4R. Oh, so I'm sorry. This is a inferior MI. That is a V4R, I think. So then, of course, this is the patient with the. If you look at this patient with the posterior, right? So then you have to assess inferior MI in 3 ways: RV infarction and posterior extension. And then if those are there, you so then posterior infarction is there, you can do the V7, V8. And then if those are there, so you have to be fluid given slowly, not the acute way. Okay. And this is my patient who came with SC elevation with the with the RBP. This patient, if you look at this patient also, anyway, LV function is low. Fluid should be resuscitated very differently to the inferior MI. Inferior MI also have a different category, right? And this is that patient going into PCI and then successfully done the PCI and went on. So then these are only one or 2 minutes. So the patient presented with chest pain and these findings how to approach: left bundle branch block, right bundle branch block, pacing rhythm, AVR, ST elevation with universal ST depressions. So if these are there, given the clinical history is very suggestive, chest pain and setting. So ideally, echocardiogram is essential because, you know, echo will show whether the patient has a left bundle branch block and a non-STEMI. You can have a right bundle branch block with a non-STEMI. But of course, if you can do echo on site, if you see the large area of infarction, you can go for thrombolysis. But of course, now current guidelines say these patients should be triaged to the STEMI pathway rather than non-STEMI pathway. So, you know, this patient should be sent to primary PCI ideally, all these patients, even right bundle branch block. Of course, when you have, if you have echo, you can differentiate much easier because you will be, STEMIs will have large area of ischemia by echo. So this is guideline. And this is another patient who came to our cath lab with very recently with a STEMI, anterior STEMI. If you look at this, there are a lot of locks everywhere, triple vessel disease. So this patient need to go to bypass. Now the current guideline is to stop dual antiplatelet before bypass. So then, and after bypass, you start antiplatelet to all antiplatelet to stop if early bypass, and then after that 12 months. I'm sorry. Okay. And this is another patient. You should know this is a Whelan syndrome patient. If you look at the ECG, this patient should be go to the cath lab. Even these are equivalent of STEMIs. So in this patient, possibly because very arrow-headed ST depressions and T inversion should go early as possible. This is a De Winter syndrome patient, which is, if you look at, there's a tall T with upsloping ST depressions in anteriorly, which is also should go to cath lab as early as possible. Their proximal LAD is severely narrowed or nearly blocked. These patients treating is maybe completed, more important than maybe completed infarction. We can save the myocardium on this patient rather. Sometimes infarcted patient, death myocardium. So take home messages, the diagnosis of STEMI and equivalent are important. So then give appropriate antiplatelet, if possible, primary PCI. If not, then PCI delays, you thrombolyze. Then even after thrombolyze successful, you send, ideally you should do the PCI. The medications should be checked before discharge, dual antiplatelet, beta blockers, ACE inhibitors, statin, and PPI, and if the EF is low, spironolactone. And then secondary prevention as next lecture. And then patient should be referred to ideally cardiac rehabilitation, which is also have a survival benefits. Thank you very much.